When we discuss about when we discuss about the types of atrial septal defect with their locations, then we see the diagrams in which include we must see these positions here, these structures: AS32 ostium secundum defect, fossa valis, AVST ostium premium defect, coronary sinus defect, sinus venous defect. Now we discuss about the presentations. Presentation here exactly. So number one is fatigue, shortness of breath, growth retardation, frequent respiratory infections, and persistent murmur. Now we discuss about the diagnostics. So we the diagnosis include ECG, X-ray, echocardiography, sometimes cardiac catheterization. 2D echo is also included, in which right-sided chambers are dilated, right ventricle volume overload. There is a discontinuity in IAS with an echo dropout at apical for chamber view. Since the IAS is thin and parallel to the scanning beam, the reflected echo signal is weak. Therefore, standard parasternal and apical views are not reliable for diagnosing ASD. Subcostal view is best for visualizing IAS. TEE allows excellent visualization of the IAS and more accurate diagnosis of patent foramen ovale. The PSAX view at the aortic valve level may show the septal defect and a dilated PA. Now we discuss about the contrast echo due to technical difficulties and limitations of 2D echo and Doppler. A contrast echo study should be performed if an ASD is strongly suspected on clinical grounds. For normal contrast study, a small bolus of agitated saline with air bubbles is injected into a peripheral vein. The air bubbles are seen in RA and they normally enter into RV. The patient is asked to perform Valsalva maneuver. The air bubbles are shunting from right to left atrium across the ASD. This is known as positive contrast effect. A negative contrast effect is observed when there is an area of non-contrast agent in the RA due to washout of contrast by normal blood flow from the LA. Now we discuss about the Doppler calculations. The PA pressure can be estimated from the tricuspid peak flow velocity and pulmonary hypertension can be identified. A combination of ASD with pulmonary hypertension is known as Eisenmenger reaction. The quantity of left to right shunt can be estimated from the ratio between pulmonary and systematic stroke volume, which is QP ratio QS. QS is aortic outflow, QP is pulmonary outflow. QP is greater than QS since a portion of LA, left atrium, output goes to the right atrium. Now we discuss about the TTE and AST. Transthoracic echocardiography for chamber view to evaluate arterial septal defect, note presence of interarterial communication between left and right atrium. TTE after intervention. Transthoracic echocardiogram for chamber view 1 day after Amplatzer device placement. AS Now we saw a diagram in which AST device closure is, and these include 4 steps: step 1 says, step 2, step 3, and step 4. Now we discuss about complete resolution of shunt. Transthoracic echocardiogram 1 day after Amplatzer device placed with highlighted area that shows no further shunting of blood across the septal arterial septal.